The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome back, TMD warriors. We are gathered here for the next episode of TMD Demystified, and my name is Tony Urbanek. Today's episode is entitled, "You Must Understand a Disease Before You Can Treat It Successfully." Kind of logical, right? If you're gonna treat a disease successfully, you must understand the disease first. I don't know anybody who'd want to argue that. Maybe some of you would. If you would, I'd be interested in talking to you. But the disease we're talking about on TMD Demystified is TMD, temporomandibular joint disorder, singular. To confront some of you out there, it is not a group of diseases. It is a singular disease, temporomandibular joint disorder, and the common denominator, spoiler alert, is inflammation in the joint, which drives each and every disparate symptom. That is why it is a disorder, because it does have a common denominator, which is inflammation within the temporomandibular joint. But getting back and making my point about the title, you must understand a disease before you can treat it successfully. And so I just gave you the key element of understanding TMD. And that was the discovery that I take credit for. It's hard to call it a discovery because all of this information has been in the scientific literature for the better part, if not in excess of 50 to 60 years, maybe even 70 years. So the information is there to look at. What I discovered was connecting the dots that had already been there to prove that all the disparate symptoms are driven by chronic inflammation within the temporomandibular joint. Now, I have beat on this concept many times on many different episodes, but the point of this episode is to compare and contrast it to what is actually being done or used in the general nature by dentists and dental schools trying to put a square peg through a round hole in treating TMD. At the very least is their efforts to treat TMD just by treating a particular symptom in that list of disparate symptoms and calling it a day. For example, I think the best example out there is the use of botulinum toxin A, or better known as Botox. Botox is almost a generic term now rather than botulinum toxin A, to paralyze muscles or a muscle. If the patient says it hurts there, you paralyze that muscle with botulinum toxin A, Botox. That muscle cannot contract. Therefore, the muscle will not pull on the bone where the nociceptors are, where the pain receptors are, where that muscle has origin insertion, and therefore the pain in that muscle derived from that muscle will go away. But what about the pain that goes over to this side of the face, or the pain that is associated with holding the neck still and neck pain, or tinnitus, subjective hearing loss and vertigo, or earaches? Botulinum toxin A, Botox, does not address any of those that's injected into a particular muscle. Beyond that, botulinum toxin A is not is not qualified by the FDA as to be used for TMD. It is used off-label at your own risk if you're going to do this. And so if you damage a facial nerve, and it has happened multiple times, injecting botulinum toxin A in a place it shouldn't be, and you paralyze part of the face, which takes 3 to 4 months then to recover. In the meantime, you have paralysis of certain parts of the facial muscles. Say muscles of mastication is one thing. Facial muscles are driven by the seventh nerve, and if you in the vernacular bag the seventh nerve, you're going to have paralysis of the seventh nerve wherever it innervates. And you have now done that at your own risk because it is not FDA approved to be used for TMD. And so there are many downfalls and things that would prove that although it's popular because the Botox people have a lot of money to spend on advertising and convincing an increasing number of dentists that they should add that to their line of work, injecting Botox into facial muscles, that really can cause some significant problems and significant damage to a patient that is not considered in the general nature of things. And then thirdly, a very well put together scientific article was published in the January issue of Journal of Oral Maxillofacial Surgery that scientifically, statistically shows that injecting botulinum toxin A into a masseter muscle, a jaw muscle, or using saline gives the same result. So a saline injection and a botulinum toxin A injection does the exact same thing, according to a very well substantiated article in the Journal of Oral and Maxillofacial Surgery, January 2023. So obviously, those who use Botox, doctors out there, dentists out there, really don't understand the disease. So let's go through this understanding of the disease a little bit deeper, because once you understand the disease, then it becomes very apparent the right kind of treatment to treat the disease, rather than the best example that I used was Botox, but there are many others. Dry needling is another. You can, if you are a physical therapist, or I've even heard of dentists starting to dry needle, put a dry needle, not injecting anything, just needling a muscle to the point where the muscle relaxes. And it is a physiologic phenomenon. I agree, it is a physiologic phenomenon. If you stick a needle enough times in a muscle, you will get the muscle to relax. And when the muscle relaxes, it doesn't pull on the bone and doesn't stimulate the nociceptors in the periosteum. And whatever pain is generated by that particular muscle will dissipate again. But what about the other disparate symptoms that are rapidly and associated with TMD? So what I found and can prove is that chronic inflammation within the temporomandibular joint drives all the symptoms. And the mechanism, here it is, here's the mechanism that occurs when you have temporomandibular joint inflammation that creates each and every symptom of the symptom list, which includes frequent and or recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, feeling of fullness in the ears, like you have water in the ear and it won't dissipate when you haven't been swimming, dizziness and or vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And it has been shown in multiple ways, scientifically, academically, that if you decrease the chronic inflammation within the joint adequately, each and every one of those symptoms will dissipate and go away over time. They all don't go away simultaneously because the chronic inflammation works through two separate mechanisms to make it happen. But the primary mechanism is the following. If a joint, and this applies to any joint in the body, if you are a dentist, you were taught that this joint is unique, different, unlike any other joint in the body. That was a big lie. That was an untruth. That is not true. This joint operates just like the elbow, or just like the hip, or just like the knee, or just like the wrist. It has the same physiologic mechanisms like any other joint in the body. Of course, it's in a different place. Of course, it's shaped a little differently. It's attached to the jaw on both sides, unlike other joints, but the hips are similar in that the joint is attached to the pelvis and operate independently the legs, while this joint is attached to the skull and dependently operate a single bone. But the point is two joints operating in unison one way or another. But this joint operates like any other joint in the body, and here's the physiologic operation that has been well known in the literature for better than 50 years. It is part of the autonomic nervous system coordination of muscles, whether they be physiologic or non-physiologic. But under the autonomic nervous system, the sympathetic portion of the autonomic nervous system, which is the fight or flight portion of the autonomic nervous system, which regulates fight or flight, whether it be something exterior to the body. Someone attacking you with a knife would stimulate the sympathetic portion of the autonomic nervous system to give you the fight or flight response, to battle it or to remove yourself from the situation. That will be an external stimulation, but the body also has internal stimulations that will stimulate the fight or flight part of the autonomic nervous system, the sympathetic portion. And one of the internal stimulants that will stimulate the fight or flight part of the autonomic nervous system is chronic inflammation. Inflammation that goes beyond the normal healing type of cells with inflammation. Don't forget, I'm a cell biologist by training and an anatomist, cell biologist, anatomist by training, and familiar with this. The chronic inflammation, which develops when normal inflammation does not go on to healing, and the cell types change somewhat, and the motion and the development of cells are different under chronic inflammation. But under chronic inflammation, it stimulates the sympathetic portion of the autonomic nervous system. And when this joint becomes inflamed, a signal is sent through the sympathetic portion to the brain, specifically the brain stem, that announces it's inflamed. When that signal arrives in the brain stem acknowledges it, modulates it, and sends back a signal, says, I understand you are inflamed, I'm going to help you heal, and sends a signal to all the muscles that move the jaw joints to tighten up, to contract, don't move the joint. That's how you help a joint to heal. And actually, tennis elbow and TMD are the same disease. Tennis elbow has the exact same physiologic mechanism working with it. When the lateral epicondyle of the elbow is chronically inflamed because of too much tennis or too much repetitive motion of the forearm, a signal is sent to the brain stem, says, I'm inflamed. The brain stem says, I see you're inflamed. Don't move the elbow, and the signal goes down, not to the elbow, to the muscles that move the elbow to tighten up, contract. When they get that signal, they tighten up, contract wherever those muscles are attached to the bone of the forearm, the ulnar radius, and they pull on the periosteum where the nociceptors are located, the pain receptors are located. It stimulates pain, and the pain then goes back and registered in the brain and in the brain stem as pain. Well, that's exact same mechanism occurs with the temporomandibular joint, and the muscles get tight and the muscles pull on the bone, not always at the same time, not always on the same day, not always on the same side. And that is why these pains move around on the face and can occur in any of the muscles that are associated with mastication. There are six major muscles, including the mylohyoid, masseter, temporalis, medial and external pterygoids. And those muscles, when they get signals to get tight, they will pull on the bone and stimulate the nociceptors in the periosteum, and the patient will elicit pain in that particular area. So you can see, going back to the example of Botox, how stupid it is to actually address just a symptom on one particular area when those signals can travel wherever they want to end up and on the muscles of mastication, and then factor in all of the potential side effects and risks that you entail by using Botox just to perform a action on one particular muscle. You can see how actually dumb that is. If you can decrease inflammation within the joint and handle all of the potential pains of headache and jaw pain, upper back and shoulder pain, arm, hand, finger tingling and numbness, which is generated by the neck muscles when they get stimulated, squeezing the brachial plexus, when just by decreasing inflammation in the joint, we'll handle all of the disparate symptoms. The second mechanism is chronic inflammation within the temporomandibular joint getting into the middle ear through the petrotympanic fissure, an actual fissure, which allows inflammatory fluids and exudates to get from the temporomandibular joint glenoid fossa through the petrotympanic fissure into the middle ear, which then will cause tinnitus, subjective hearing loss, and vertigo. And of course, chronic inflammation within the temporomandibular joint will stimulate the external auditory canal because of the paper-thin wall between the glenoid fossa of the temporomandibular joint and the external auditory canal. And the patients will say, I have ear pain, and the ENT doctor or convenient care clinic nurse practitioner will look in there and they go, no, you do not have an ear infection. Your tympanic membrane looks normal. I don't even see any inflammation in there at all, where the inflammation doesn't come from the outside of the external auditory canal. It's coming from the inside of the external auditory canal through that paper-thin wall between the glenoid fossa and the external auditory canal. It separates those two structures, but by a very, very fine paper-thin wall of bone and periosteum. And then finally, the locking is associated with changes in the synovial fluid. Chronic inflammation within the joint causes the synovial fluid, which is supposed to be a lubricant, to turn into a glue, a sticky glue, which then causes the meniscus, the disc, to dislocate, pulls the meniscus around. The meniscus is not pulled forward by muscles. It gets gluey, it gets sticky in there, and as the joint tries to open and close and translate forward, it pulls the disc out of position. The disc gets pushed out of position and glued, literally glued, in front of the temporal bone, which causes then various types of locking. That explains the whole thing, why and how the mechanism of temporomandibular joint problems occur. It is the mechanism. Now, there are lots of examples in medicine, where the treatment at large was done constantly, but was ineffective because the doctors performing it didn't understand. A great example was bloodletting. Bloodletting was started actually thousands of years ago, but extremely popular in the Middle Ages, all the way up until the 19th century. Um, um, Early America, the medical doctors, Dr. Rush, who is actually the founder, or at least one of the founders of medicine in the United States of America at the turn of the 17th century, was basically a bloodletter. And if whatever disease you had, that was the usual and customary treatment, was to bleed the patient down. He was also a psychiatrist, and he recommended bloodletting for psychiatric problems. Obviously, he did not understand the disease when he recommended bloodletting for various physical and mental disabilities. But that occurred quite some time. Dr. James Costin, who actually is one of the originators of the concept of temporomandibular joint syndrome, headache, earache, jaw pain, who wrote one of the first papers, if not the first paper, describing the symptoms, and it was called Costin syndrome from 1934 when he published this paper describing the symptoms and recommending that the cause was lack of posterior teeth, lack of support for the temporomandibular joint because there weren't adequate posterior teeth, and the recommendation was dentures, replacement of posterior support with dentures. Well, he obviously didn't understand the disease. And then even as late as 1969, when one of our icons in oral and maxillofacial surgery, Dr. Daniel Laskin, University of Illinois, wrote his seminal paper in 1969. I think it was published in the, I believe, the January issue of the Journal of American Dental Association, 1969, where his theory, he admitted it was a theory, was associated with the worn out muscles because of too much bruxism, and the muscles would get worn out because of excess clenching and grinding, causing pain in the muscles. Well, muscles don't have pain sensors in them. The pain sensors are in the periosteum, and just because a muscle wears out does not make it painful. It can feel like it's burning if anybody goes to the gym and lifts frequently. They're familiar with that phenomenon of a feeling of burning. That is actually the wearing out of the muscle. But the actual pain is associated by too much contraction of the muscle, consistently generated by the autonomic nervous system sympathetic portion, which is driven by a signal from the brainstem, which receives a signal from the temporomandibular joint, says, I'm inflamed. Brainstem says, tighten up. When you tighten up the muscle consistently without relaxation, it's going to pull on the periosteum, stimulate the nociceptors, and you will have pain right there. And the patients will come in the morning, doc, it hurts right there every morning, and show you the insertion of the temporalis. Or they say I have neck pain, and they'll point to the sternocleidomastoid insertion. Or the trapezius insertion, say it hurts right there. They're pointing to where the muscles are attached to the bone and they pull on the periosteum. So again, you must understand a disease before you can treat it successfully. And unfortunately, in the United States of America and worldwide, the dental profession and the dental schools and the dental literature has not got to the point where they understand the pathophysiology, understand what is actually happening in this disease. They call it temporomandibular joint disorders, and really, because it has multiple symptoms, Those are just the symptoms. A symptom is not a disorder. A symptom is just a symptom of a disorder. And what the disorder is damage to the joint caused by bruxism, acute trauma, or functional malocclusion, which creates chronic inflammation. Chronic inflammation is the common denominator which drives all of the symptoms, and that is the pathophysiology of TMD, disorder, singular. By the way, I'll just throw in the tic douloureux, trigeminal neuralgia, is a catch-all. It's just a phrase. It's a phrase that indicates trigeminal neuralgia, pain associated with the trigeminal nerve. Well, what does that mean? All it means is pain that is associated with the trigeminal nerve. It's not a disease in itself. It's a description of where the symptoms may be located in the distribution of the trigeminal nerve. That's not a disease. It's a description of where the disease is located. Trigeminal neuralgia, pain of the distribution of the trigeminal nerve. V1, V2, and V3. That's the state. That is where we are, and that's what I'm trying to solve. How do you solve this problem? You unload the joint with a device that unloads the joint by separating the back teeth long enough, because 90% of the loads on the back teeth just go into the temporomandibular joint. 90% of the loads on the temporomandibular joint are caused by posterior occlusion. If you disocclude the posterior teeth according to a protocol, 24/7 for 2 months, nighttime only the rest of your life, it allows the inflammation within the temporomandibular joint to decrease without drugs, without physical therapy, without Botox, or without narcotics, without psychiatric drugs, without dry needling. And it's quite a simple device to use. You do have to be consistent. You have to have good patient compliance. You have to have good knowledge from the doctor who performs the service. But I've just explained the nuts and bolts in the past 30 minutes. It's quite simple. If you'd like to learn more about this, you can see more details and more information, success stories, and whatever on our website, urbanektmj.com. If you'd like to discuss it with me, if you'd like to criticize what I have to say, I can be reached at tony@tmjservices.net, tony@tmjservices.net. If you happen to be a patient and looking for a doctor who can perform this service for you, we have a page on our website, urbanektmj.com, which elicits all of the doctors throughout the United States who are licensed to use this device because it's patented, FDA cleared, independent university study, that are licensed and go through the training process to use it successfully. And that list can be found on our website, urbanektmj.com. If you'd like to become a network provider yourself, again, I direct you to the website or contact me individually would be just fine too. So that's it for today. I hope I made my point. I've certainly tried to. You must understand a disease before you can treat it successfully. And this definitely applies to the disease that we call temporomandibular joint disorder. With that said, I look forward to the next episode, which I always record on a Tuesday. I hope to see you again. I am Tony Urbanek, and this is TMD Demystified.